Good morning, everyone. I'm Dr. Ujjayini, and we are going to talk about mechanical ventilation. So, what are the basics of mechanical ventilation? So, what is the definition first? So, we use mechanical ventilator to remove room air or oxygen from the atmosphere, and then we're going to push it into the lungs by providing positive pressure to maintain proper levels of oxygen and carbon dioxide in the blood. So, it's nothing but an extracorporeal support system. So, what are the indications for using ventilator? For any acute respiratory failure or any impending failure or severe hypoxia or hypoxemia, the patient has gone for respiratory muscle fatigue or any cardiac insufficiencies, neurological problems whereby the patient is not able to take proper breaths, or therapeutic and prophylactic uses of mechanical ventilators. So, what is our goal? First of all, our goal while using ventilator is to avoid lung injury and thereby reducing oxygen toxicity and recruiting the alveoli by using recruitment maneuver, or which are nothing but by increasing the mean airway pressures or by increasing the positive end expiratory pressure or by prolonging the inspiration or by decreasing the peak airway pressures, preventing atelectasis, using sedation and paralysis so that there is no ventilator and patient dysynchrony. So these are all goals. So mechanical ventilator, you have two types: negative pressure ventilators and positive pressure ventilation. So these are called. This is a picture of negative pressure ventilators, which were used previously for during seasickness or any trauma during diving. So diving injuries. So in such cases, we use negative pressure ventilator. But what we use in daily life is positive pressure ventilation. So, what are the parameters in a mechanical ventilator? So, tidal volume, respiratory rate, which is nothing but number of respirations we take or provide per minute. So, that is what we label it as frequency here. Then we can say something called peak inspiratory pressures, positive end expiratory pressure, inspiratory time, expiratory time, and the ratio between these two. So, inspiratory expiratory ratio. So, what are the terminologies we should know before entering into this topic? So, there is something called independent variables and dependent variables. So, independent variables are already set by the clinicians. The parameters, what are all we set as a doctor or a clinician. For instance, tidal volume or respiratory rate, or IE ratio, these parameters are set by the clinicians, and these are called as independent variables. There is dependent variables or something measured by the ventilator. Ventilator measures the patient's requirement and then delivers it. So these are called as dependent variables. What is called as FiO2? There's nothing but fraction of inspired oxygen concentration. As we breathe in the room air, we inspire about 21% of oxygen from the atmosphere that is normally available. Whereas in a ventilator, this 21% can be provided up to 100%. This FiO2 can be provided up to 100% by a mechanical ventilator. So that is the main advantage. And we can further reduce it to the goal of minimum FiO2 during weaning process. Then coming to tidal volume. So it is the amount described as the amount of air delivered to patient per breath. And we express it as milliliters. So in a tidal volume setting, we start with 6 to 8 ml per kg of ideal body weight. So ideal body weight is something that takes into consideration of patient's gender and height as well. Then we something called respiratory rate. So respiratory rate, we usually set it somewhere to a near physiological rates of 14 to 20 breaths per minute to maintain normocapnia. And coming to minute ventilation. Minute ventilation is the product of tidal volume and respiratory rate, which we express as liters per minute. And something called exhaled tidal volume. This is the amount of gas that comes out of patient or lung during exhalation. So it is the most accurate method wherein we can understand the volume received by the patient. So whatever volume we give, for instance, we give tidal volume of ml per kg. By measuring the exhaled tidal volume, we can come to a conclusion how much the patient has received. Exactly. If at all the exhaled tidal volume deviates from the set tidal volume by 50 ml or more, then we have to troubleshoot the system. There is some kind of leak. The inspiratory expiratory ratio. It is nothing but the time amount of seconds spent during inspiration and amount of seconds spent during expiration. So it mimics something like spontaneous breathing. So during spontaneous breathing, normal IE ratio is 1:2, which means that we spend 1 second on inspiration and 2 seconds during expiration. So whereas if exhalation time is too short, that is, if the exhalation time is somewhere between 1.5, or if it is even less than the inspiration time, then there is no adequate time to left over to wash out the air present in the lung. That leads to something called breath stacking or auto breathing. This is very disastrous if the patient is already having auto breathing, as in case of COPD or bronchial asthma. So in such cases, you can change the ratio. You can increase the expiratory time. By increasing the E ratio, you can provide more time for exhalation. Depending on disease process, if at all in ARDS, you require more oxygenation. So in such cases, you have to increase the inspiratory time. So IE ratio can be inverse. It is called as inverse ratio ventilation, wherein the inspiratory time can be increased more than expiratory time, so that the time for oxygenation, the time during inspiration is spent more and oxygenation improves. So here it is called inverse inspiratory to expiratory ratio. So normal inspiratory expiratory ratio is 1:2. If at all it is reversed, if the inspiratory time is more than expiratory time, as in case of if it is equal also 1:1 or 2:1 or 3:1, then it is called inverse ratio ventilation. Most commonly we use it as a part and parcel of ARDS management. It also prevents the atelectasis. Coming to P, positive end expiratory pressure. So this is the amount of air left in the lungs to prevent atelectasis or atelectotrauma or collapsibility of the lungs. So normally we set P from 5 to 20 centimeters of water to prevent collapsing of airway, and it also increases the functional residual capacity, thereby increases the oxygenation. So what is called an auto PEEP? Auto PEEP is nothing but physiologically we have something called PEEP in our body. Spontaneous development of PEEP because of gas trapping that results in insufficient expiratory, resulting from insufficient expiratory time and complete exhalation, that is called as auto PEEP. So normally we give adequate time, that is at least twice the time of inspiratory time to exhale out the amount of gas left in our lungs. If it is not going to happen, if expiratory time is not adequate, then that results in breath stacking and something called auto PEEP. So causes of auto PEEP can be because of rapid respiratory rate, or high volume of tidal volume, or high demand for tidal volume, or airflow obstruction, as in case of asthma, or inverse IE ratio ventilation, inspiratory expiratory ratio ventilation can also cause auto PEEP. You can measure auto PEEP by using this formula. Total PEEP, you can measure from this graphical representation minus set PEEP. So, for instance, the total PEEP of the patient, including the auto PEEP, is somewhere between 10 centimeters of water, and the PEEP we have set is 5 centimeters of water. So, the auto PEEP is going to be 5 centimeters of water. So, effects of auto PEEP. What are all the adverse cardiopulmonary effects? So, already we know that PEEP is going to going to create a positive intrathoracic pressure, thereby reduces the preload by compressing the vessels which bring blood to the heart. So that is going to happen if the PEEP is going to be already present, there is already auto PEEPing present, and additionally you are going to add some more PEEP. So it is going to result in adverse effects by increasing the intrathoracic pressure, and causes hemodynamic instability by reducing the cardiac output. And increased pressures can also result in pneumothorax and pneumomediastinum. Again, the thing is ineffective ventilation can lead to air trapping, can lead to ineffective ventilation, collapse of capillaries that can result in dead space ventilation, which worsens hypercarbia and hypoxemia. Once the lungs are over-distended, gas exchange is ineffective because it compresses the surrounding capillaries. This results in CO2, that is carbon dioxide retention. And what is called as sensitivity or trigger sensitivity. So it controls the amount of patient effort needed to initiate inspiration. So for initiating an inspiration, I should generate some amount of negative pressure. So if the sensitivity is going to be low, if I take even -1 or -2 centimeters of negative pressure, water of negative pressure, that is sufficient to initiate inspiration. So increase in the sensitivity, that is requiring less negative force, reduces the amount of work. So in order to reduce work of breathing, we increase the sensitivity. If we decrease the sensitivity, then the patient has to put more effort to generate a negative pressure to achieve the same amount of work to be done. So thereby that results in increased work of breathing. So our goal is to increase the sensitivity. The most common setting is going to be between -1 to -2 centimeters of water. Once the patient breathes to -1 or -2 centimeters of water, the inspiratory phase will starts generating. Peak airway pressure. So it is the pressure required to deliver the tidal volume to the pressure. It is like a positive airway pressure. So you are pushing the air into the lungs. Plateau pressure is nothing but intra-alveolar pressure. So it is the pressure needed to distend the lung. So during the plateau phase. So it can be obtained by applying the end inspiratory pause or hold. So at the end of inspiration, you put a hold and measure the pressure. So that is the intra-alveolar pressure or plateau pressure. So it is going to reflect the compliance of the airway, and it should be maintained somewhere between 30 to 35 centimeters of water. Less than 35 centimeters of water is ideal. If the patient is extremely obese or pregnant, then you can allow up to 35 centimeters of water. So this is a picture showing how to measure the plateau pressure. So here, see the pressure. At the end of inspiration, you are going to put a hold. So that is called as inspiratory breath hold. Thereby, you can measure the plateau pressure. And then something is called as peak airway pressure. So difference between peak pressure and plateau pressure is called as ohmic resistance. So it is going to indicate the airway resistance. So it can help in differentiating between bronchial asthma and COPD also. So peak inspiratory pressure is the maximum pressure in the airway at the end of inspiratory phase. So once the inspiratory phase is over, still there is some amount of pressure left in the airway to push furthermore air into the lungs. So the maximum pressure which is available is called as peak inspiratory pressure. So it should be maintained less than 35 centimeters of water to prevent barotrauma. There is something called as driving pressure concept. So it is a new concept. It is included in ARDS management also. It is nothing but it is a difference between the peak plateau and peak expiratory and expiratory pressure. So it should be less than 14 centimeters of water. So it describes the pressure changes that occur during inspiration and is equal to difference between plateau pressure and peak. So for instance, the peak plateau for the patient is 30 centimeters of water and you have applied a peak of 10 centimeters of water. So the driving pressure, there is a difference between these two is going to be 20 centimeters of water. But our goal should be less than 14 centimeters of water according to trials. Right? Now, difference between resistance and compliance. So resistance is change in pressure to change in per unit change in volume. So that is what you change it, you call it as resistance. It is the impedance of flow in any tubing or airways to the airflow. Okay, compliance is nothing but it is the reversal of resistance. It is inversely proportional to resistance. That is change in volume per unit change in pressure. So how to troubleshoot peak inspiratory pressures? If it is more high, it should be less than 35 centimeters of water. So how are we going to troubleshoot it? We are going to provide something called inspiratory pause. So once you put the patient on inspiratory pause, there will be no further flow of airflow into the airway. That removes the resistance and there will be presence of only complaints. So the lungs will expand, but there will be no more resistance present. So thereby you can troubleshoot the increased peak inspiratory pressures. But if at all, we already saw in previous slides there about the peak airway diagram and the plateau pressure. If the difference is going to be very high, then it means that airway resistance is high or ohmic resistance is high. So what are all the causes for increased airway resistance? So King TT tube, bronchospasm, mucus plugging. If we use small size ET tube or any obstructive lung disease, these are going to increase the resistance. So what are the conditions which are going to reduce the complaints? They are nothing but mainstem intubation, atelectasis, pulmonary edema, ARDS, pneumothorax, obesity, restrictive lung diseases. So like ARDS. Okay, so it's one among the restrictive air lung disease. So these are going to reduce the complaints. So let's go to ventilator basics. So what are the control or target value variables? So these are nothing but modes of ventilation. So we have something called pressure controlled, volume controlled. In pressure control, we are going to set the pressure. The clinician is going to set the pressure that is delivered with every breath. In volume control, we are going to set the designated tidal volume. What are the conditional variables? Conditional variables are dependent variables which the ventilator measures in a patient and accordingly it will deliver a breath. For instance, in volume control ventilation, the tidal volume, we are going to set, the clinician is going to set the tidal volume. While the ventilator measures the pressure and then it provides the pressure which is good for the patient for from one breath to another breath. Coming to phase variables. So phase variables are nothing. We have three phase variables: trigger, cycle, and limit. So trigger variable is going to trigger your inspiration. It is going to initiate. So when our inspiration can be triggered, or how the flow can when the flow can be triggered. So it is based and further classified into pressure trigger, flow trigger, and time trigger. So which is going to initiate? That is the basics cycle. It is going to determine the end of inspiration. So trigger is going to initiate and cycle is going to end. And it's causes beginning of exhalation. For example, mechanical ventilator can be volume cycle, pressure cycle, or time cycle. Coming to limited the limits. So controls inspiratory inflow. So how much flow is required? So it can be flow limited. So once the adequate flow is achieved, then it will stop providing it. Or it could be pressure limited. Once the adequate pressure is delivered to prevent further barotrauma, it will stop providing the increased pressure. Then phases of mechanical breathing. Initiation phase and inspiratory phase. We have something called initiation phase. It is the starting of the mechanical breath. It can be triggered by the patient or the mechanical ventilator. Once the patient initiated breath, you will notice a slight negative reflection because we, as humans, we take in breath by providing negative pressure ventilation, right? We produce a negative pressure inside the airway, and thereby we start sucking from the atmosphere. Inspiratory phase. It is a position of mechanical breathing during which there is a flow of air into the patient's lungs to achieve the maximal pressure, that is peak airway pressure or a tidal volume, which is required for the patient's ventilation. And something called plateau phase. So it not in every mechanical ventilated patients you need a plateau phase, but it is important to prevent barotrauma, because once the plateau pressure starts increasing, the alveoli have to expand, and at one point it may rupture. When coming to cycle phase. So when the inspiration ends and next expiration begins. So once inspiration ends and the expiration begins and it ends, becomes one cycle. So that is called cycle phase. Exhalation phase. The start of the exhalation process can be either volume cycle, time cycle, or flow cycle. Once you achieve the adequate volume, the inspiration stops and exhalation starts. Or we can set a time in the settings as seconds. Once the adequate seconds are completed, then it can result in exhalation. Or once the adequate flow has been achieved, then it can switch over to exhalation. So waveforms and loops. So we have something called scalars and loops. Scalars are nothing but we are going to plot pressure, volume, or flow against time. Time will be in x-axis. Whereas loops, we are going to plot pressure, volume, or flow against each other, one another. But there is no time component in loops. So what are the 6 basic waveforms? Look at this picture. The first one is called a square waveform or rectangular or constant waveform. The second is called as ascending graph. Third is called descending graph. And we have something called sinusoidal or sine wave, exponential rising, and exponential decaying. So these are all 6 waveforms. So pressure volume loops. Volume is plotted on the y-axis here. So as we saw, and pressure on the x-axis. In loops, there is no time component. So it is among one another, volume, pressure, or flow. So here in pressure volume loops, volume in y-axis and pressure on x-axis. Inspiratory curve will be towards upward. Look at this picture. And expiratory curve is towards downwards. So spontaneous breaths go clockwise and positive pressure breaths go counterclockwise. The bottom of the loop will be set at the set peak level. And will be if there, and it will be at 0. There is no peak has been set, but we have to set at least a minimum of peak of 5 centimeters of the loop. If an imaginary line is drawn down the middle of the loop, the area to the right represents inspiratory resistance, and anything that is left to the towards the left side represents expiratory resistance. So pressure volume goes. So as we discussed, this B part indicates expiration and A part indicates inspiration. So inspiratory resistance or resistive work of breathing is towards the right side, and expiratory resistance elastic work of breathing is towards left side. Something called inflection points, lower inflection point and upper inflection point. So lower inflection point is the point where the lung starts opening, the alveoli starts opening. So it is a point where just above the lower inflection point is a point where we apply the peak. And upper inflection point is the phase where the alveoli is maximally distended. So once it causes a upper inflection point, it should not provide more pressure, which may result in barotrauma. So this is the significance of upper and lower inflection point. Coming to flow volume loop. Here flow is plotted on y-axis and volume on x-axis. So it is used for ventilating graphics now for understanding the pulmonary function test. So inspiration is above the horizontal line and expiration is below the horizontal line. So the shape of the expiratory flow represents the passive exhalation. If it is long and more drawn out in patients with less recoil. It can be used to determine peak inspiratory flow, peak expiratory flow, and tidal volume. Coming to flow volume loops, here look at the picture. So it is from the 0 point, it is the start of inspiration. So it takes a loop and comes down, and the peak, the conical projection is the peak expiratory flow. The basic modes: control mechanical ventilation, something called assist control, intermittent mandatory ventilation, synchronized intermittent mandatory ventilation, pressure support ventilation, and combinations of all these. So control mandatory ventilation. So we are going to preset the tidal volume at a time triggered or respiratory rate. As ventilator controls both tidal volume and respiratory, the ventilator controls the patient's minute volume or ventilation, irrespective of patient's respiratory rate. So volume control ventilation. So here we are going to provide the tidal volume. Set volume is delivered with each breath. So the machine will assess the pressure required in each breath, and it will deliver it as a dependent variable. So pressure control ventilation, here we will set the pressure, and the machine will measure the volume required in each breath, and it will provide it. So the advantage of this mode is it prevents ventilator induced lung injury, and in ARDS also. So this is volume control mode. The peak flow, it will be in square waveform. Whereas in pressure controlled, it will be in decelerator, either ascending or descending ramp waveform. Indications: for any tetanus or seizure activities that interrupt the delivery of mechanical ventilation, or complete rest of patient is required for 24 hours or more, for the crusty chest injuries, or if there is any paradoxical chest movements, or if the patient is under heavy sedation or muscle relaxant. So complications of sedated or apneic patients, there is a potential for apnea or hypoxia if at all the ventilator gets disconnected, or if the ventilator fails to operate, or it can result in disease atrophy of diaphragm muscles, or something called ventilator-induced lung injury, oxidative injury to diaphragm. It results in elevated proteolysis and barotrauma, volley trauma. In coming to assist control ventilation. So mechanical breaths may be either patient triggered or by patient spontaneous efforts, or time triggered by a preset frequency. It is terminated by volume cycle. So preset volume is delivered. We set the volume and it gets delivered. And ventilator cycle to expiration. So mode provides full ventilator support for patients when we first placed on mechanical ventilation. Volume assist control and pressure assist control. So volume assist control requires frequency of respiration per minute, whereas pressure assist control, it is time cycled ventilator support in which constant pressure is applied to the airway opening. Indications of assist control: patient is stable respiratory, and if they are conscious, then we can use it as a weaning. Advantages: patient's work of breathing requirement is very low, and there is no the buildup of PaCO2. Also, complications: it can result in hyperventilation, respiratory alkalosis, breath stacking, and high volume and pressure. Intermittent mandatory ventilation. So, patient is allowed to breathe spontaneously from either a demand valve or a continuous flow of gases, but not offering any inspiratory assistance. So, what are all the advantages? Freedom for natural spontaneous breaths, even on machine, and lesser chances of hyperventilation. Whereas the disadvantages are asynchrony, random chance of breath stacking, increased work of breathing, random high airway pressures, and lung volumes. SIMD, or synchronized intermittent mandatory ventilation. So ventilator delivers either assisted breaths to the patient at the beginning of a spontaneous breath or time-triggered mandatory breaths. Mandatory breaths are synchronized with the patient's spontaneous breathing effect so as to avoid breath stacking. So to prevent dysynchrony between the patient and ventilator, we devised the system, and it was used as a weaning mode also. So three types of breathing: patient-initiated assisted ventilation, ventilator-generated controlled ventilation, unassisted spontaneous breathing. What is the indication? To provide partial ventilator support. So the advantages are avoids atrophy, disease atrophy, reduces ventilation perfusion mismatch, decreases mean air pressure, and facilitates weaning. Disadvantages: sometimes it may lead to weaning failure also. Pressure support ventilation. So it determines the respiratory rate, the minute ventilation required, and inspiratory time, and it is purely spontaneous mode. What are all the parameters involved? Triggers. Inspiratory triggers, limited by pressure, and affects only inspiration. Uses: it can be used to overcome resistance. It can be used as a weaning mode and provide and let the patient breathe spontaneously. Disadvantages is the each breath has to be initiated by the patient. Can result in hypocapnia, respiratory alkalosis, or weaning failure also. The advantages of each one. Coming to assist control ventilation, it reduces the work of breathing compared to spontaneous breathing. Coming to AC, that is assist control volume ventilation, guarantees delivery of set tidal volume. Coming to assist control pressure control ventilation, it allows limitation of peak inspiratory pressures. Pressure support ventilation, patient's comfort, and improve patient ventilator interaction. Synchronized intermittent mandatory ventilation, it results in less interference with normal cardiovascular function. Disadvantages of assist control ventilation is potential adverse hemodynamic effects, hemodynamic instability, or hyperventilation. Coming to assist control volume ventilation, excessive inspiratory pressures resulting in barotrauma. Assist control pressure control ventilation can result in hypoventilation, hyperventilation, increased lung resistance, and collapse also. Pressure support ventilation there is no backup alarm, so variable patient tolerance. In SAMV mode, increased work of breathing compared to assist control. So thank you. That is about mechanical ventilation.